Yes, thank you. Let me also give a warm welcome to all friends, colleagues from different parts of the world. Just make sure that you can see my screen.
Yes, can see your screen.
Okay. And so I purposely put this background over here because I think we are today in a world of or a galaxy where the treatments for BPE seem to be coming up just like stars and going away as well, equally fast. But we are living in the world of minimally invasive treatment, and this is the focus of my talks will be dominantly on Rezum and Exim, but I'll touch upon a few other technologies. So with that, I would like to say that we all know that basically the work in BPH happened, most of it was on understanding the pathogenesis, understanding the pathophysiology, and then there was medical management, which went on till about 2000, just about early 2000. And first follow-up was actually described in 1998, but it never really took off from then. I think it's probably due to the lasers. But if you look at 2013, when the first proposition of aqua ablation came in, this actually it was a landmark paper that came out, but not because of aqua ablation itself. But it actually brought about another letter to the editor, which was a very challenging question, which was asked. We keep saying TRP is a gold standard, and it was a very incisive letter, which actually said the failed idea of gold standard is because who decides what is a gold standard? And we feel that instead of blindly following what is called as gold standard, look at the evidence ourselves. This kind of opened up the mindset to proceed in a big flurry with the newer modalities of management for BPH. And we do know that when we talk about BPH complex, we are constantly talking about the dynamic component, the static component, the shapes, and every single aspect of prostate management, whether it's the static or dynamic component, has been looked into as a way to understand how this influences bladder outlet obstruction, as well as has given us a clear pathway in understanding what mechanism of treatment will act at what level. And we had only TURP or just a laser enucleation until very recently. But then recently, with the better understanding and a free, I would say, free flow of treatment modalities that have come in, we have a lot of urology intervention that's happening for prostates. And the need for change is necessary. And if you really look at it, and this is a slide which I had made earlier, what do? We either remove prostate tissue, we either injure it or scar it, or we basically open the prostate. And these have been the primary modalities of tackling any problems with the prostate. We have different treatment options between each. And what's really happened is that this is one of them which is really taken off in a bigger way. It used to be only tuna. It was always criticized. And we look at how Rezum sort of takes over from where tuna left. What's very important is 20 years ago, we used to talk about the prostate size as small and big and just do this. And in 2020, we are basically talking about removing the tissue or not removing the tissue, at the same time providing a modality of treatment which can suit different patients, different sizes, as well as offer the option of maintaining sexual preservation while still being able to void. And I basically think treating a prostate today, once the AUA guidelines which said, large prostate, average prostate, small prostate, is just like cooking an egg. You can cook an egg in several different ways based on how you like it, which basically attributes to the availability of treatment or the experience that you have, and evidence which shows that this is a good treatment for maybe this age. If you look at this is a HOLEP, if you morcellate the prostate, and this is scrambled egg. It's very similar. And I think today's prostate is being cooked in different modalities, but there are certain things which are better than the other. Let's take a look at what may be a good way forward. And I would take the slide off Prof. Tebevo, who basically said, if you look at prostate treatment today, the more effective the prostate treatment gets, we probably have more side effects because it's more invasive. So the lesser side effects and maybe equally effective would be these three today. We've spoken about Urolift and PAE, so I'm going to try and touch upon Rezum. And why is that? Is because the first question I think most of us face in the wards, in the OPD, is a patient asking, Doc, after this procedure, can I void and can I have sex? So I think that is a very pertinent question today. And that's why Rezum has probably started to gain more momentum. What exactly is happening over here is that the company has revived this technology, and a new generator has been created which gives you heat applied to a prostate within the zones of the prostate, and it actually allows this heat to have a very delivered, targeted, precise mechanism. When you fire that gun, it raises the temperature to almost 500 calories mil, which basically creates a phase change. What that does is basically a convective wave technology, which is by this company. What that really does is that it allows the heat to go up about 103 degrees of water vapor is created, and that water vapor diffuses into the prostate and then causes a heating of the cells of the prostate in that zone in which you fire to about 70 degrees. Now, why is that 70 degrees so important? Because it immediately causes cell death, and it also seals the vasculature. It causes denervation of the fibers, and it's a very efficient and uniform and a predictable treatment because you are targeting it. Unlike the other older modalities like tuna, where it was not targeted and it did not really have these precise mechanisms which have been better understood over time. And I think what's important is that it's over time, because tissue is ablated and resorbed by the body, reducing the volume of tissue. A very important point here is that when you finish Rezum, you have to keep a catheter, because this line where it is resorbed by the body, reducing the volume of tissue, it takes time, and you need to give that time for the patient to recover. So when you counsel a patient, it's something which you have to basically bear in mind. And the key, this was a 4-year study which came in, and it was a sham control study. They've also included the median lobes, and it was a good 60-month follow-up. We'll talk about the 5-year results now. And what really is being done is, if you look at this animation and a real video over here, it's you take your Rezum needle or fire the gun inside, where exactly to the zone that you want, you insert that little needle, you fire, like I said, 103 degrees of water vapor for 9 full seconds will create a 70-degree temperature in that environment, and then it will damage or rather kill the cells over there. And I would choose a patient who's a sexually active male, maybe in the IPSS of 18 to 22, which is bothersome. He does not want, or he's basically cannot afford medical therapy, because we know medical therapy in the long run can be expensive. He definitely is a bit worried about post-op incontinence. And like I mentioned, sexual dysfunction is important. And he wants a cost-effective procedure, because if you compare medical treatment for 5 years versus Rezum, it actually is pretty affordable and cheaper as compared to even procedures like tuna or HOLEP, if you start taking all the instruments that go into doing the procedure. So this is a newer modality which is coming to Singapore as well. So I thought we'll discuss it over here. I had the experience of working with, rather learning it from Dr. Richard Henley. I'm very keen to have clinical experience now. And they've shown if you compare Rezum to MTOP study, it's much better compared to the MTOP medical management. And in the takeaways of the 4-year study, they actually had only a 4.4 surgical retreatment rate. That means most of the patients had very good improvement in IPSS, in Qmax, in quality of life, and most importantly, sexual function was well preserved. Non-serious adverse events were very infrequent. Yes, there is dysuria. That's something which you have to bear in mind, but it's temporary. And the 5-year study now, actually, the retreatment rate, because the recruitment has been across different centers, the retreatment rate has about 15.5%, but it has been only usually about the 5th year. So maybe if you have a patient who really wants a 5-year free interval before he goes in for something more active, take him off the medications, allow him to continue his sexual life, a young man, and Rezum will probably be his go-to treatment soon. And it's FDA approved. And so what's important is, Professor Richard Henley always says, you have to tell your patients, he's going to hate you for a month when he has that, probably that time when he has to customize to the catheter and to the dysuria. But after that, he's going to love you because he's going to be able to void very well. So a very key point in counseling the patient is important for Rezum. And the other topic that I'm alluding to is stents. And my love for stents has always been there. It was never really something which a lot of people have taken to, because in 2011 there was always the talk about stents. There are different kinds, metal, non-metal, and different companies which make them. They're all been tried and tested and failed. And I think the main reason they failed was because it was a lot of dysuria that it created. They were not tolerated. They were migrating easily, difficult to take out, bleeding, and basically it's stents which really don't serve the purpose as well as they talk about it. There was then this interesting stent which came out, which is Alien. And this was an Israeli company. And two of my friends have logged in over here. So hi, guys, from Israel. Yes, this stent was very interesting because it was very comfortable, very easy to put in. They did a short study and they said, yeah, it's great. It works really well. But for some reason, it did not take off from 2015 until 2019. 2019, there's a renewed interest, and it's coming out with a different name. We'll see that a little further down. But what it really did was it reintroduced the concepts of stents. And today, Rocomed, I say today because it's only recently, has come in with this exciting stent, you can say, which is basically Rezum. It's an innovative device. It sort of comes in the offering when a patient comes to you with ARU or with is having a chronic retention on a catheter for a long time. So this is an interesting device because it can be done as an outpatient in about 10 to 20 minutes. There's a training model which you do. You calibrate the urethra, and then after that you take this little device under LA and you gently insert it. And the device sits very nicely across the prostatic urethra in a very easily doable way as an outpatient procedure under LA. This is also something which is coming to Singapore. I think COVID has sort of delayed its entry, but I'm told that it will be here soon. It's a very promising modality. It's been allowed right now for 1 month for the device to stay inside. So you don't have a bag and the patient can actually go back to normal work. One of the professors who was who was part of the designing team actually tried it on himself. And in a very recent webinar, when I asked him, he said, I could cycle, I could have sex, I could keep this and void very comfortably. It did not cause any dysuria, did not cause any pain. Very encouraging. And it was apparently because one day he had constipation and he had this problem. So we do have patients who come to us with ARU. So this may be a way forward, and this may be a new beginning for stents to come in. And I think practical experience will tell us how well it works. In Europe, it's very easily available. It's CE approved, and hopefully it will be FDA approved soon as well. So with that, I think they actually recommend it's safe. It has absolutely no impotence and incontinence. It helps you, like I said, maintain sexual activity. In the studies that they have done, which are a fair number of them, it actually is the preferred choice over catheterization because there's a natural filling and emptying of the bladder. You do not feel the sensation. Apparently, the material is really, really good. And there's also some evidence to say that the colonization by bacteria is much lesser. So you don't really need too many antibiotics, which is all some things which patients on catheters don't want. And we also worry as urologists. So a very exciting device, which again is coming soon. Will be interesting to see how it shapes up in a population in the Asian world. Apart from that, there are lots of new toys in the horizon. I just wanted to show that this is something which friends of ours in Singapore have tried in an experimental way. Is water electrolysis. Remember that slide I showed you? You can do so many things to the prostate. You can cook it in so many ways. So these are all the various options. This is a very interesting device which is being used for prostates which are medium-sized. And basically what it does is causes pressure necrosis and opens up. So I don't know. I'm just showing you these as points of interest. Don't have a personal experience on them. This is again something which is a handheld device, uses an outpatient, and there's an electrocutting current which puts the ring into the prostate and keeps it open. Easily done, apparently in just about 15 minutes, and keeps the patency of the prostatic urethra open for years together. The Zentlo is just a similar one. They actually say recommended leaving it in for those maybe post-prostatic intervention strictures, or even for BPH, where these rings can stay in permanently. Or usually if the patient wants it to be removed, it can also be removed quite easily. And if you look at the picture, it actually looks quite impressive. But things are new and they have to be tried. And there's lots of trials which are actually happening, and people are showing promising results. Like I said, this by end of this year, we will know where we stand with the Zenflow. This seems to be a very promising modality coming up. Apart from that, the balloons are back into force. We can actually coat them with the paclitaxel. The Optilume seems to be very promising right now. Very recently FDA approved iTint, and it's a temporary implantable nitinol device. And this is very easily done as an outpatient. The small little video, which is by Professor Enrique Rizzo, I've taken it off from him. And it's done in, again, a very easy outpatient setting. You put the device in, you put your flexible cystoscope, you watch the device to be, you open up the device, and it's like a Mercedes-Benz symbol, where at the 12 o'clock and at the 9 o'clock and the 3 o'clock position, the device opens up and the wires get embedded, and then they cause pressure necrosis. And there's a promising outcome in the 1 year follow-up. So hopefully this is something which I think with time we'll know whether it's comfortable and easy and for the patients to use. And then along with this, this is something which is exciting as well. It's histotripsy. It has been tried on every single tissue, which is basically what you do is you create a hyperechoic bubble. So you put your rectal probe and you see this acoustic bubble, which creates fissures, or it creates small little insults into the prostatic tissue and then ablates them. And this is being used for tumors very frequently, and now they are trying to advocate it for the use of a prostatic enlargement as well. And the first patient in University of Michigan actually had his trial. So things are getting hot, things are becoming a reality. But the question is, as of now, we just have iTint, Urolift, and Rezum as FDA approved, and more promising modalities of treatment for the time being. So I think at this point of time, the question which everybody asks is, because we are during COVID times, how does COVID change the way we treat BPH? And I think this is where minimally invasive treatment for BPH is really taking off. If you look at all these options, which some of them which I mentioned too, I haven't even spoken about injections or not only botulinum injection, but actually medication injections into the prostate, which completely ablate the prostate. We're talking about local anesthesia-based modalities. In COVID times, especially if they can be useful, iTint is an intraprostatic stents seem to be promising. Ronnie has spoken about Urolift, which is quite promising and as most widely accepted modality all over. Rezum is gaining importance, it's gaining momentum. So I think with all these options available, the question should be probably changed to, could this open up new opportunities for minimally invasive treatment, just thanks to the fact that COVID is making us think otherwise. And if you look at it, these are favorable options because the mechanism of actions are very well understood. They can be used on most prostate size. It's local anesthesia, hardly any contraindications, more advantages than disadvantages. And I think that's probably the future of things to come. So thank you so much.
Right. Thank you, Vinny. So I just suffice it for me to say that half a century after the TURP was essentially developed, we're still looking for ways to cook the prostate. So a couple of questions here. One, a question of opinion to you. Do you think the Rezum will replace all the other techniques? Just as a personal question.
I don't think anything can replace any single modality of treatment. But like Urolift is so widely accepted, I think Rezum will be a very widely accepted procedure of choice. The only problem being that you have to counsel the patient that he needs a catheter for at least a month, sometimes after the procedure is the Achilles heel. But like I said, or rather Dr. Hindley said, initially the patient is unhappy, but eventually the patient will be happy.
Right. There's another question. I think it's reference to Exim stent. Is there an estimated cost? Well, for us in Singapore, have we got an idea how much it will cost? Yeah, but I think the company hasn't mentioned about the cost. They wanted to bring it in actually early January, but because of COVID, they've had to delay it. So the more acceptance, I think, will bring down the cost. But I think it's about 300 euros, if I'm not mistaken. So not the cheapest. So I must say that ESWL in the realm of ESWL, which is what my area is, we have mentioned about histotrypsy before. So I see it's nice to see it come back again, although the original discussions about prostate and histotrypsy wasn't too encouraging. Well, thank you, Vinit, for taking us essentially through the exhibitors panel for a conference which we are all not attending now.